So we talked about some of the cardiovascular etiologies that we're going to look for, either exclude or maybe directly diagnose with point-of-care ultrasound. Now let's talk about the respiratory questions. Say we've ruled out all the cardiovascular things, or we're thinking CHF, but we want to look at the lungs and get us a little more information. So here's our list of questions. So first one, is there a pneumothorax or not? Now, this is probably not as common in most emergency departments or inpatients where there's not trauma, but these do happen spontaneously, especially on patients who have been on the ventilator with high pressure settings, or they've got blebs or long-standing COPD. So definitely something that we have to think about sometimes. So here are our respiratory causes. Let's start off with the extrapulmonary things like pneumothorax. So the main findings are going to be lack of sliding and a lung point. Remember, most of the time the air is going to go to the most anti-dependent area. So think about where that is on your supine patient. Put the probe on the place closest to the ceiling. So that's question number one. Do we see pneumothorax? And this one is pretty straightforward, and this can help us distinguish between spontaneous pneumothorax versus maybe auto PEEP in the patient who's decompensating on the ventilator. So here we see lung sliding, pretty intact underneath the ribs, rib shadows here. Here we've got ribs. We can see movement in the chest, but we see no lung sliding at all. So this patient likely has pneumothorax. Here's what it may look like over here. A little arrow again to point out for you. There's the sliding, and we don't see the sliding over here. Probably would want to see it right under here. There's a rib with a shadow, and we don't see any lung sliding in there. Now, sometimes, and depending on how much we want to search for it, if we just get lucky and end up in the right place, we may see a lung point. This is the interface between where the visceral pleura and the parietal pleura are together versus where they are no longer together. And you can see it kind of change as the patient breathes in and out. So the point kind of pops up and then pops back, pops up, pops back. So this is a lung point. This is generally 100% specific for the diagnosis of pneumothorax. Now, still doesn't necessarily tell you how big it is, but tells you it's definitely there. Now, there are a few things to watch out for that can fool you. You may just see the interface between the heart and the pleura, and that may look like a lung point, so just be aware of that and cognizant of that. We may see solid organs if we're close to the abdomen, and some of these patients, their abdomen can be all the way up almost the axillary line, so be a little careful of that. Here we're seeing, I'm not sure if we're seeing liver or kidney or what we're seeing here, but we see a transition between pleural line and something else with a solid abdominal organ. So those are examples of false lung points. We could see this with any kind of fluid collection in the chest, consolidation in the chest, so don't let those fool you. Make sure what you're seeing on the non-lung side of the lung point is actually just the absence of lung, and there's no other fluid or mass or other piece of tissue that's fooling you. So with those findings in mind, we can look at this patient who's admitted with ARDS, they're on a ventilator, increasing pressures, getting hypoxic and hypotensive. We're trying to decide, is this an auto PEEP phenomenon or is this pneumothorax? Do we want to empirically just needle the chest or not? And in this case, we can say, with reasonable confidence, probably no pneumothorax. We see lung sliding on both sides. So that can help us in this case. Or if we see the pneumothorax, we can be more confident in making that decision to go ahead and perform a needle or tube thoracostomy. So that's the first one. Is there pneumothorax or not? Not going to be that common that we're worried about that in most of our inpatients, but it will come up, and if we see it, it's drastically going to change the way we manage that patient. So next, is there a pleural collection or not? We're usually going to start with our views of the diaphragms to find these. So over in this extra pulmonary category, we talked about pneumothorax. Now we'll talk about pleural collections. Usually we're going to talk about fluid, but there may be other things. So that's respiratory question number 2. Is there a pleural collection? And most of the time, again, it's going to be simple fluid. We identify the diaphragm, and then we can see, is there fluid here? And we usually like to examine it and see how much is there. We can see the spine sign. We can even see the descending thoracic aorta here. Sometimes it may be incredibly stranded and incredibly complex, like you might see with this empyema over here. But again, this is a pleural collection that may be resulting in shortness of breath in this patient and going to alter the way we treat them. And then we'll have to make a decision. Is this something that we're going to drain here at the bedside, or how do we want to manage this moving forward? So this is our next case we looked at earlier. They've been short of breath for a few days. We hear crackles and wheezes. Maybe we see reasonable left ventricular function, maybe we don't, but we see this large pleural effusion and we decide maybe we're going to do other medical therapy, but with this large of a pleural effusion, there's no way we're going to resolve this patient's hypoxia without draining it. When to drain it is going to be an individualized decision based on the whole patient. At some point, there's a threshold where we're going to decide, you know what, we need to drain this fluid. There's no other way that we're going to treat this that's going to have significant enough impact on this patient. But knowing that this is there is going to help us. Reminder and point out that chest x-rays drastically underestimate the size of pleural effusions, much more accurate with ultrasound, and again, quicker, faster, cheaper, less radiation than doing this with a CT scan. And certainly not something you can do with someone who's decompensating in front of you. So that's the first two. Is it a pneumothorax? Is there a pleural collection? And then the next thing, kind of last thing we can look for with ultrasound that may help us is, do we see inflammatory or infectious findings? So that's those, and we'll break those down. So we've talked about these extrapulmonary things, and now we're going to get into these lower respiratory things. Parenchymal disease is next. So we're going to look for pleural abnormalities, B-lines, other lesions. And that's our third question. So if we see thickening or irregularity of the pleura, now when we're looking for this, the more lung we look at, the better. So if this is kind of on your list and what you're thinking, where you may want to add in those posterior lung views as well, or especially in pediatrics, where we'll see thickening. These are pretty profound. Irregular, thickened pleura is all they look all chewed up and nasty. These are signs of inflammatory or infectious problems going on in the lungs themselves. And the distribution of this or the burden of this is going to help us decide. This, obviously, these are things we may see in COVID patients. We may see small little lesions. Sometimes people call these consolidations or subpleural consolidations. We see B-lines associated with these. This consolidation makes you think that this is probably inflammatory. A lung infarct could look like this as well, so correlate it with other things. Here we just see kind of thickening, irregularity, and like a chewed out nature to the pleural line with lots of B-lines around it. These are signs of inflammatory or infectious change in the lungs. In this example here, the pleural line looks pretty good, but what we see here is we just see these B-lines kind of in one focal area popping in and out of this place. And if we're to look at the rest of this patient's lungs, we don't see much of that anywhere. So if we see B-lines in just kind of one or two focal areas, or they're skipping around into different spots in the lungs, think of that as being infectious or inflammatory as well. Over here we see kind of B-lines, we see these skipped out areas. So this is another area where we see irregularity, skipped out B-lines. These are signs of infectious or inflammatory things, as opposed to pulmonary edema, where the B-lines are very regularly distributed, they run together, and they're fairly symmetric. So that's one of the ways you can help differentiate pulmonary edema from infectious and inflammatory findings in the lungs. And then we get some really profound and really nasty things in the lungs when they get really filled up with consolidation. So here's a big example where we see, let's just pause that a second. So this is diaphragm here. We see the liver below. This is all lung. These white dots here are sonographic air bronchograms. So the air within the bronchi is white. So this is a massively consolidated lung. And earlier in the clip, we saw lots of B-lines associated with that. So we see a lot of B-lines. And as we move to a different part of the lung, we can actually see this whole thing is consolidated and filled with pneumonia, infiltrate, infection. All these white dots are air bronchograms. So we'll let that play. Similar thing over here. This is, I think, the heart beating here, and this is all left chest. This looks like liver, but this is all lung. All of this is consolidated lung. These white dots here are air bronchograms within the lung. So this is a really profound and severe consolidation. This could happen from severe atelectasis, like maybe a huge mucus plug in the main stem bronchus. There's a high likelihood that this is infectious or inflammatory. So massively consolidated lungs. So this is what parenchymal disease looks like. Irregular B-lines, patchy distribution, skipping around. So that's what we see here. We may see thickening or irregular pleura, like we see here, or other more severe or profound lesions like here. We may see little small dipped out consolidations, or these very large, massive consolidations that take up an entire hemithorax. So that brings us back to this case that clinically my thinking was maybe this was some CHF at first, but they're a little hypotensive. They're going to be tricky to manage, but with a little bit of lung ultrasound, we're able to look and see that this is probably an infectious inflammatory thing, probably pneumonia associated with septic shock, and we can treat them appropriately with their other physiologic findings in mind. So lung ultrasound going to drastically help us make these diagnoses. And again, just like with pleural effusion and pneumothorax, ultrasound is also more accurate for these findings as well. So just a quick summary, some of the respiratory causes that we looked at. So the extrapulmonary things like pneumothorax, that's going to show us maybe a lack of sliding or lung points, okay? Plural collections, usually going to be fluid, but sometimes it's more complex, and then we'll have to decide when do they reach the threshold of requiring invasive treatment. Within our lower respiratory things, we talked about the skipping around or irregularly distributed B-lines, the pleural thickening or abnormalities, and then the either smaller subpleural or even larger pulmonary lesions. So that's parenchymal disease. And then the last one, which we don't directly see with ultrasound, but given clinical history and the absence of these other findings, we may be able to make the diagnosis of, is this a COPD or an asthma or obstructive pulmonary disease exacerbation? So even though no positive diagnostic findings, the absence of other findings, and given the rest of the clinical picture, maybe we hear wheezing or they have a history of these, may lead us into this is a pure play COPD or a pure play asthma exacerbation that's not complicated by something else. So those are our big questions. In the absence of other findings, then we may, again, given the right clinical history, may be dealing with COPD or asthma.